Hello, everybody. Welcome to the session. We have a great presentation today with Dr. Andrew Pipe is joining us from the University of Ottawa Heart Institute. He's a professor in the Faculty of Medicine at the University of Ottawa, and he's Canada's foremost expert on smoking cessation. He was instrumental in the development of the widely adopted Ottawa model for smoking cessation at the Heart Institute. Without further ado, I will pass it over to Dr. Pipe.
Well, good afternoon, and thank you all for joining this afternoon. It's a pleasure to be with you. It's probably a good thing that there's no video of my presence here today. As a consequence of social distancing, I look somewhat hirsute and unrespectable, so I'll spare you those grisly images. Today, I thought what we would talk about is smoking cessation within the context of the COVID pandemic and briefly discuss some of the issues that have emerged in recent weeks before moving on to talk about fundamental basic approaches to smoking cessation using nicotine replacement therapy as the model for those approaches. It's important to recognize that outside of childhood vaccination, there is nothing that any clinician in any setting can do that is as powerful a preventive intervention as helping a patient stop smoking. Important to remind ourselves that nicotine is the most addictive substance in our community. An addiction to nicotine develops very, very rapidly. And that is particularly the case when we begin to discuss various forms of e-cigarettes, which hopefully we will address in a fleeting manner later in our discussion today. It's also important to recognize that if we help individuals stop smoking before they reach the age of 40, we can eliminate virtually 90% of the predictable premature death and premature disease that otherwise is associated with this addiction. And it's also important to remind ourselves that smokers will lose at least 10 years of life expectancy as compared with those who have never smoked. Well, obviously today we are very appropriately preoccupied with understanding the COVID-19 virus and understanding ways in which smoking may or may not impact or interrelate with this virus. And as you are aware, the coronavirus the COVID-19 virus is a coronavirus, very common viruses which typically cause mild illness, but variants of the coronavirus, of which the COVID-19 is the latest, can cause very substantial and significant illnesses. And in Canada, of course, we are familiar with SARS, and in the Middle East, an outbreak of what is termed Middle East respiratory syndrome is also attributable to the COVID-19 virus. And as a consequence of the lethality and the prevalence of this virus, we have encountered a pandemic in Canada. For many, many, many years, scientists and clinicians have been saying it was not a question of if, but when we would face an outbreak of an infectious disease of a very significant dimension. And of course, that reality has now come home to roost, so to speak, and has revealed some surprising weaknesses in our system. But overall, in comparison to others, we have done not as badly as might have been anticipated as a consequence of the enactment of appropriate public health measures. It's always a pleasure to be as up to date as possible, and this is data that was recovered just an hour or so ago. There have been more than 78,000 confirmed cases in Canada, of which approximately 40,000 as of yesterday had recovered, but there have been more than 5,800 deaths. Now, I would also want to put this into context because, of course, these are deaths that, to the extent possible, might be considered preventable. And so far this year, we've had 5,800. In Canada, approximately 47,000 Canadians pay with their lives every year as a consequence of the disease and the duplicity, which are products of the tobacco industry in Canada. More of that to come. But it's important to put that into context. We know that the coronavirus is transmitted typically in aerosolized droplets, which are distributed when one speaks, when one coughs, or one sneezes, and can persist in the air for several minutes after they have been exhaled or expelled. It's also important to know that smokers typically have less resistance to respiratory infections, therefore have frequent respiratory illnesses, and of course, hand-to-mouth behavior is part and parcel of cigarette smoking or e-cigarette utilization. And as we know, it's the hand-to-mouth movement that may transmit viruses picked up from hard surfaces or from contact with others and deposit them around the nose and the mouth that lead to ultimately the infection. And of course, the principal initial site of that infection is the lungs. And what we also know is that the lungs of smokers are less capable of cleaning themselves, clearing themselves, and the fundamental mechanisms which are built into the lungs designed to resist infection and to kill invaders of various forms are impaired in smokers. And so it's not surprising that a few weeks ago, this article appeared in Nicotine and Tobacco Research, a prestigious journal that points out, exactly as we've just noted, the main entrance of the virus through the mucosal tissues of the mouth, the fact that tobacco smoke exposure results in inflammatory processes in the lung and reduces the ability of the lung to protect itself from invaders. And therefore, in the words of these authors, it's very important that public health campaigns should include reference to smoking cessation during the course of the pandemic that we're currently experiencing. One of the reasons why smoking cessation and smoking may be interrelated with the COVID-19 pandemic is that the COVID virus bonds to these ACE2 receptors, these little devices which are noted on this slide, and I don't seem to be able to get the arrow, there we go, bond to these ACE2 receptors in various tissues. And we know that smokers generally tend to have a much higher number of these ACE2 receptors. Therefore, it seems rational to think that as a consequence of smoking, the greater availability of these receptors, that any exposure to COVID-19 is more likely to result in the adhesion of the COVID-19 virus to this receptor. And the literature in the last few weeks have been clear that it makes sense that public health strategies should be employed to identify the role that smoking can play in the COVID-19 pandemic. So far, we've been talking about cigarettes, but what we know about e-cigarettes is that they have similar effects on the lung, that they change the mechanisms and the function of the airways that deliver air to the tissues of the lung. They also tend to minimize the ability or reduce the ability of the lung to resist invaders. And when we get down to the air sacs in the lung, where air is actually exchanged through gossamer thin membranes into the blood that passes by, we see that there are changes in alveolar function, which also impair respiratory function. Once again, evidence of the fact that when you inhale anything other than air into your lungs, it's reasonable to expect that there will ultimately be damage. What we know is that vaping liquids contain a variety of substances which are known to cause damage to the lung. We also know that this is early data that comes from Wuhan in China, shows that individuals who are smokers tend to have more severe forms of COVID-19 as a consequence, presumably, of the degree to which their lungs are incapable of resisting the invasion of the COVID-19 virus. So far, this all makes perfectly good sense. And the evidence has continued to be distilled and published, and always comes to the same conclusion that smoking is most likely associated with negative progression and adverse outcomes of COVID-19. And then intriguingly, in other jurisdictions, most specifically the United Kingdom, public health authorities have used the COVID-19 pandemic as an opportunity to point out the benefits of smoking cessation, and the reports of smokers in the United Kingdom show that more than half of them have tried to quit or reduce as a consequence of COVID-19. And in an article which appeared in The Guardian a few weeks ago, that number has been estimated as being 300,000. There is no such data currently available in Canada, and I think it is intriguing to note that in Canada we really haven't very substantially or in a comprehensive fashion, raised the issue of smoking cessation insofar as the COVID-19 pandemic is concerned. But then the story becomes a little bit more confusing, or does it? And we'll discuss this for the next moment or two. Authors in France noted that in their hospital institutions, the number of smokers with COVID-19, that is the percentage of those with COVID-19 who were smokers, was lower than the percentage of smokers in the general French population. And they felt, therefore, that this could indicate a relationship between smoking and a reduced tendency to have COVID-19 illness. And this article was published in an online journal, intriguingly called, or I guess you pronounce it this way, Chaos, a few weeks ago. And in that same publication, also we saw another analysis that suggested that current smoking is not supported as being an argument for being a risk factor for hospitalization for COVID-19 and might suggest a protective role. And that obviously raises a number of questions. And the hypothesis, which I'll attempt to explain, is that COVID-19 may interact with the receptors which we know are distinctly related with smoking. And therefore, if one is smoking and nicotine is a key that goes into this receptor lock, if COVID-19 comes along, it can't bind to this receptor. And why is that important? Because these receptors, when stimulated, can often cause a very substantial inflammatory response. And it's that very substantial disseminated inflammatory response which can cause very significant respiratory and other complications in those with COVID-19. Now, it's also important to note that this data relates to individuals who are hospitalized. It doesn't necessarily address the relationship that might occur with smokers who are not hospitalized and have less severe forms of the disease, but nonetheless may in that other setting have just as many incidents of disease, if not more, than non-smokers. And of course, we should not forget that nicotine is a highly abusive drug, the most addictive drug we have in our community, and has unbelievable pathological consequences such that it takes 10 years off the life expectancy of most smokers. So let's just examine this a little bit more carefully. Here is the alpha-4 beta-2 nicotinic receptor, which we think is the grandfather or grandparent of all of the nicotine receptors and is principally responsible when stimulated for the initiation of a whole array of processes in the brain that cement addiction. Now, nicotine ordinarily attaches itself to this receptor. And remember that this receptor, when stimulated, can in certain situations cause a very substantial inflammatory response. So if nicotine is the key in the lock, when COVID-19 comes along, it can't attach itself to this receptor. And therefore, it can't induce that very complex form of inflammation. Is this a reasonable hypothesis? Is this plausible? Well, the answer is yes. We know that in certain conditions caused by very significant inflammation, it has been noted that nicotine can reduce the level of inflammation that results. Classically, this is true of those with Crohn's disease and inflammatory bowel disorder. So there is some plausibility to this approach. But I would suggest that it's too early to come to any valid conclusions about this. Among other things, when individuals are presenting to emergency departments in acute respiratory distress, when the emergency room is awash with people who require immediate or rapid ventilation, when the ICU is teeming with such patients, that's not the time that people are necessarily asking the questions about smoking status and getting appropriate and accurate replies. It's quite typical that many smokers deny their smoking status when presenting to hospital environments. So there's much, much more to come in this question. Nevertheless, there are some intriguing suggestions from this preliminary data. So that's smoking in the, or pardon me, some contemporary issues that surround smoking in the pandemic circumstances. Let's just talk though about the impact of COVID-19 and the pandemic on how, pardon me, in terms of the factors that might influence cessation. We know that most smokers smoke not only because of their addiction, but also because there are certain settings or situations or circumstances that trigger an urge to smoke. And this is sort of a situational reinforcement kind of model. We know that now that individuals are at home, working from home, or removed from their day-to-day workplace or other typical environment, that many of those cues, many of those settings and situations have now been eliminated, which suggests that it might be easier for such individuals to stop smoking. On the other hand, being at home, facing the challenges of finance and the stresses of being in what might be a crowded environment with family members, limited access to the outdoors, etc., can be predicted to increase significant levels of stress, making it arguably more difficult for such individuals to stop smoking, because a smoker's immediate response to stress is generally to smoke. As well, we have to understand that there might be in that environment pressures to quit from non-smoking family members and others, which, on the other hand, to go back to the other side, may reinforce an intention to stop smoking. Boredom may also be occurring, and that unfortunately, in many situations, leads to increased smoking. We talked about the financial challenges. One of the reasons why many individuals do stop smoking is because of the cost of tobacco products. And of course, the health concerns with which we began this discussion and the relationship between COVID-19, lung function, and respiratory illness and COVID-19 obviously weigh heavy on the minds of many. So there are very opportune times in terms of smoking cessation, but there also may be challenges as a consequence of the circumstances that we're facing. And of course, if we want to help individuals stop smoking, there are also some challenges. We don't have the same kind of personal contact. Levels of stress may be heightened, as we've just noted. Clinicians do not generally have the same kind of interactions or the same quantity or perhaps quality of interactions that might afford them the opportunity to offer with smoking cessation assistance as they may have in the past. Whereas we also now can approach individuals virtually. And the value of those initial virtual contacts can be very substantial, particularly at a time when people are socially distanced and crave the kind of contacts and conversations that can follow with telemedicine, teleclinic kind of interactions. We can make available the expertise and experience of those who are active in smoking cessation practice. We can do so efficiently, and as a consequence of modern telecommunications, it's relatively easy to be in touch with and to assist individuals with smoking cessation. And the slide, or pardon me, the schema on the right just outlines a systematic approach to smoking cessation in this kind of context. And I think all of us involved in cardiac prevention and rehabilitation programs should be very aware of the opportunities which are afforded to us to begin to apply these techniques and these processes in this way. So the COVID-19 pandemic has also caused all of us to reconsider how our programs are configured, to address and assess alternate ways of reaching out to those in our care, now virtually, to capitalize on the value of the personal contact that is possible, to use novel messaging techniques and place an emphasis on stress reduction. We know from the work of Peter Selby and colleagues at the Center for Addiction and Mental Health that we can distribute smoking cessation medications by mail with very good effect. And we have an opportunity at this time, I would argue, to have a much broader public outreach, given the general public's understanding of the importance of prevention, given their now unfortunate recognition of the reality of significant respiratory disease and the end stage phases of respiratory diseases, which result in people being on respirators in intensive care units, which is pretty characteristic of what happens to many smokers at the endpoints of their lives. endpoints which are 10 years earlier than those of other Canadians. So one of the consequences of the COVID-19 pandemic may be that as we emerge, we have a public which is far readier to accept approaches to prevention. And hopefully we will have politicians and public policy leaders who also recognize those opportunities and will be far less sympathetic to the lobbying activities of the tobacco industry, which is unrivaled in its ability to prevent any form of regulation of its activities or its products. Well, let's move on then to smoking cessation itself. And let's just talk a little bit, if I may, about approaches to smoking cessation. And I'm going to emphasize that at the end of the day, successful smoking cessation consists of doing ordinary things extraordinarily well. And I make reference to the Ottawa model, a program that we developed in our institution, which really is all about doing ordinary things extraordinarily well, and doing so in a way which makes it far easier for healthcare professionals and makes much better use of their time and ultimately produces far better responses than the old serendipitous approach to, I see you're a smoker, it might be a good idea to quit. Why don't you mention that to your family doctor if you've got one? Kind of approach that characterized smoking cessation in the past. And the fundamental elements of this systematic approach are that we must know the actual smoking status of every patient that we see, recognizing that many smokers will deny their smoking status. When we know that smoking status and document it, a system is primed such that that documentation triggers an offer of assistance with smoking cessation, using best practice approaches, including pharmacotherapies, and then allows for follow-up. And one of the successes of the Ottawa model, I think, is entirely attributable to the degree to which these elements are incorporated into hospital or clinic policies, programs, protocols, in order to ensure that consistent, systematic approach to the identification and treatment of smokers. And of course, one of the fundamental elements of successful smoking cessation is the appropriate use of pharmacotherapy. And typically, today we talk about 4 pharmacotherapies. This slide, as you will note, only mentions 3. I'm going to talk virtually exclusively today about the use of NRT because the principles that surround the use of NRT can also be applied to the use of varenicline, which is a medication which attaches itself to that alpha-4 beta-2 nicotinic acetylcholine receptor that we saw earlier and blocks it so that the nicotine key can't get into the lock because varenicline already occupies it. And I'll make passing reference to cytosine, which is a natural product which does exactly the same thing, binds to that receptor and prevents nicotine from attaching itself to it. Well, let's just really understand that nicotine replacement therapy is used because we understand that if we can get nicotine levels up to a certain idiosyncratic or personalized comfort zone, we should be able to forestall or at least dramatically reduce the feelings of craving and the symptoms of withdrawal that come when one has not smoked for a certain period of time. And so we deliver nicotine using a variety of products, the patch being the oldest and the slowest form of nicotine delivery, the spray being perhaps one of the more recent and certainly the most rapid form of nicotine delivery. It's important to understand, however, that nicotine delivered this way is delivered slowly through the skin or the membranes of the mouth and throat and goes into the venous system. Where in contrast, when a smoker inhales or a vapor inhales nicotine, it's delivered immediately to the principal pumping chamber of the heart, and then wham, you get a stupendous surge of nicotine throughout the arterial system, and nicotine and the 5,000 other chemicals, 50 carcinogens, and huge quantities of carbon monoxide are delivered to tissues in the matter of seconds. So irrespective of how much nicotine an individual uses as they attempt cessation, they are infinitely safer than they would be if they were to continue to smoke or to vape. The advantages of these therapies are that they don't require prescription, and arguably they are cheaper, not arguably, and they are much cheaper than other smoking cessation pharmacotherapies. But the reality is that as smoking is clustered amongst those of lower socioeconomic status, often cash flow can be an important challenge. And an individual can scrape together money to buy a pack of cigarettes a day, but may not be able to have enough money to buy a box or a carton of nicotine patches, for instance. Unfortunately, these products have been used poorly in the past by both smokers and until very recently by clinicians. And let's just discuss some of those issues right now. Here is that broad red line, which represents that comfort zone of nicotine level in a particular smoker. And the jagged green line represents rising and falling levels of venous nicotine following a particular cigarette. And when nicotine levels fall to this comfort zone and start to decrease, that's when an individual gets the urge to smoke. They smoke again, and their nicotine levels rise. What's not shown on this slide are arterial levels of nicotine, which would be stupendously elevated in the context of this diagram. Well, we also see here that the standard doses of a nicotine patch or nicotine gum really don't often come close to that comfort zone, which suggests there may be, let's term it, a therapeutic gap. Well, when we provide or prescribe medications to address other cardiac issues, blood pressure, manage cholesterol, we prescribe the medication, we monitor the response, and we change the dose of that medication until such time as we get the desired response, and then we continue until the desired endpoint has been reached. And smoking cessation is no different when it comes to the use of medications to assist with cessation. Think of smoking cessation as an opening of a doorway onto a smoke-free future. And for many of our patients, that doorway has to be held open wider or held open longer, which means we must be prepared to titrate the dose, perhaps the duration of therapy, and even consider combination therapies. And how do we do that in our setting and in many others? If you're a 1-pack-a-day smoker, you get a single 21 milligram nicotine patch plus the inhaler, which is not really an inhaler, but that's what it's been termed. It's a vaporizer, which allows you in the course of the day, if you're suddenly feeling more stress or in circumstances where the urge to smoke can be more compelling, you can top up your nicotine levels with a more rapid form of nicotine delivery. If you're a 2-pack-a-day smoker, you get 2 21 milligram patches in an inhaler. If you're a 3-pack-a-day, you can do the math. And the important point to take home here is that irrespective of how much nicotine patch or how much nicotine replacement therapy is being provided, an individual is still going to get far, far less nicotine than he or she would if they were continue to smoke, and it's going to be delivered via the venous system, not the arterial system. Now, I don't want you to go away thinking that, well, Pipe from Ottawa says everybody needs boxcar loads of nicotine for prolonged periods of time. That's not my message. My message is that one must be prepared to comfortably and confidently prescribe or provide such medications for as long as is necessary in order to help people stop smoking. I quite happily ask patients to take 2, sometimes 3 medications to control their blood pressure, or a couple of medications to manage very high levels of cholesterol. And I ask them to do that for the next 25 or 30 years. And yet we've locked ourselves into this idea that we should be able to help individuals stop smoking in 10 to 12 weeks. And if that's not successful, they should go away and think more carefully about when they want to make another attempt and then come back and get more help. And so I want to underscore the fact that the prolongation of cessation therapy is entirely appropriate. And I have no qualms about asking individuals to continue with nicotine patches for 9, 10, 12 months. And certainly the use of other cessation medications like varenicline can easily be used in exactly that same way as we make every attempt to ensure ultimate smoking cessation success. So what are shortcomings of nicotine replacement therapy? Well, smokers may have preferences. They may feel they don't get some of the elements that they ordinarily associate with smoking, the throat feel, the sensations of flavor. They can't get the drug delivered as rapidly as possible, and price and ease of use have already been identified in our discussion today. Let's just talk briefly about other therapies. Cytosine is a natural product which during the Second World War in Eastern Bloc countries was used. The leaves of this plant, of the plant from which cytosine comes, were used as a tobacco substitute quite successfully. After the Iron Curtain came down, the leaves of this plant were used to make the ingredients of a smoking cessation pharmacotherapy, which was also very successful. And cytisine is that natural product. And it's available in Canada to a limited degree in various pharmacies or from the manufacturer and distributors as a product known as Crave. And as I noted earlier, cytosine attaches itself to that alpha 4 beta 2 receptor in much the same way as does nicotine, which is exactly what varenicline does. Varenicline attaches itself to that receptor to absolutely nothing else, does not interact with other medications, and is excreted from the body almost 98% unchanged. It does, however, require a prescription. And there have been reported side effects, many of which have been exaggerated, and very scrupulous examinations of varenicline and the effects of its use have failed to support the idea that this is a medication, for instance, which causes numerous psychiatric side effects. It is important to understand that individuals with mental illness or psychiatric comorbidities have much, much higher rates of smoking. And it's also important to understand that many of the phenomena which are reported as side effects of smoking cessation medications are in fact manifestations of withdrawal symptoms. So it's very important to keep those facts in mind. Well, you might quite legitimately and quite appropriately be asking me, what's the most effective agent to help individuals stop smoking? And here we see that the most effective single agent is varenicline, which can approximately triple the likelihood of successful smoking cessation. Whereas the nicotine patch used by itself, or bupropion, another medication which we haven't discussed today, an antidepressant with abilities to help with smoking cessation, both of those products can effectively double the likelihood of smoking cessation. But the combination of a slow release form of nicotine in association with a more rapid form of nicotine delivery like the gum or the vaporizer can dramatically enhance the likelihood of smoking cessation and is the most effective approach to smoking cessation, and therefore is very typical of the kind of interventions that we use in our hospital programs and in our outpatient settings. We make, I would say, almost exclusive use of nicotine patch and of varenicline, believing that when used appropriately, these afford our smokers the greatest opportunity of achieving cessation. In the community, our pharmacist colleagues are becoming much more adept and much more ready to provide support. And of course, they can prescribe in certain provinces smoking cessation medications and arrange for follow-up. A couple of quick comments about other issues in the COVID-19 era. The use of water pipes poses an array of issues, not only those related to smoking, but also, of course, the mouthpiece is shared when individuals smoke water pipes, enhancing the risk of transmission of viral illnesses. Individuals who smoke marijuana, interestingly, have a very significant interest in wanting to stop smoking, in our experience. But those who mix marijuana with tobacco leaves in order to consume marijuana are going to face very significant challenges as they attempt smoking cessation. And finally, a couple of quick comments about these devices, which have evolved rapidly in recent years. They deliver or can deliver stratospheric levels of nicotine, and best represented by a device like this, which is a so-called pod mod. It's a very sophisticated electronic device which heats a very special form of nicotine, a nicotine salt, and delivers incredibly high levels of nicotine. A single module in one of these devices delivers as much nicotine as an entire pack of cigarettes. And it's not unusual for teenagers and young adults to be using 3 or 4 of those pods in a day. Now, the manufacturers of these devices, of course, all claim that these are intended to help individuals stop smoking, despite the fact that the evidence is very clear that they've used a whole array of perfidious techniques to rapidly develop nicotine addiction among teenagers and young adults who are almost exclusively the consumers of these products. Older adults who try to attempt smoking cessation through the use of these devices inevitably, and for the most part, become what we call dual, D-U-A-L, users. They smoke regular cigarettes at certain times of the day, and they use these devices at other times of the day, and therefore their risk is not reduced at all. And in fact, the likelihood of them stopping smoking is actually substantially reduced once they begin using these devices. Nevertheless, the manufacturers of these devices, and Juul, J-U-U-L, now the most aggressively marketed and the largest, biggest seller of these e-devices, are attempting to do everything possible to evade or elude any form of regulation. And of course, a signal step in that respect was announced a few days ago when Juul announced that Rona Ambrose, a former Minister of Health, has gone onto the board of directors of Juul. Juul is partly owned, or pardon me, a significant proportion of Juul is owned by the Philip Morris Tobacco Company. And the Philip Morris Tobacco Company, on becoming involved, immediately placed one of their executives into a leadership role in the company. And his whole reputation and renown is built upon his ability to prevent governments from regulating tobacco products. And undoubtedly, he welcomes Rona Ambrose with her contacts into the fold. The tobacco industry is unrivaled in delivering three products: disease, death, and duplicity. And it's very unfortunate that retired Canadian politicians choose to go to work for such industries. We know that the revolution, if I may use that term, in the use of these devices has resulted in the course of just 2 years in the tripling of teenagers in Canada who are smoking and vaping. So the tobacco issue hasn't been addressed. We face new challenges. And in some respects, it is now not inappropriate to talk about the tobacco pandemic, because it's like COVID-19 in slow motion, in the words of these authors. And the fact is that if governments had expended as much effort and spent as much money on controlling tobacco as we most appropriately have done in addressing COVID-19, millions of lives would have been saved, and billions of dollars would have been saved as a consequence of the reduction in healthcare expenditures, which smokers incur in very large amounts. So smoking cessation, the single most powerful preventive intervention in clinical practice, has particular relevance at the time of the COVID-19 pandemic. And I think it's probably appropriate to conclude there before a final comment, and that is that assistance with smoking cessation is a fundamental responsibility of every clinician who sees patients who are smokers. And the degree to which we can be more effective in helping smokers deal with their addiction is a reflection of the degree to which we become more systematic and also employ evidence-based best practice pharmacotherapy in order to help in our response to that particular challenge. Let me thank you again for joining this way today. I'd be happy to respond to any questions, comments, or criticisms.
Great. Thank you very much, Dr. Pipe. It's Paul O speaking. It's a pleasure to be with you all again online. And I had the privilege of listening in on this wonderful session. And Dr. Pipe and I've had the privilege of knowing him for many years. And he is consistently a passionate and eloquent champion of smoking cessation, as well as heart health overall. So thank you for that terrific treatise about smoking cessation in this current era. We have some questions online, as well as some that have arisen through the course of the presentation. And if we go through things in turn, we started with the notions of smoking being a very bad thing for our health, and it continues to be a bad thing, even though we may not be talking about it as much as we are about virus at the moment. So one question that came in online was if one stops smoking, hopefully at a younger age, and they recover, Dr. Pipe, are there still, do they recover fully, or are there still some lasting effects on lung health or lung function over the long term?
Well, thank you. Very appropriate question. And it's clear that very rapidly after you stop smoking, there are very significant restorative changes that occur in lung function, lung structure, et cetera, et cetera. Now, the question, though, must be answered in terms of at what age does someone stop smoking and for how long have they been smoking? Because there's no question that if one stops early as a young adult, that likely respiratory function will recover. On the other hand, if you've been smoking for 20 or 25 years, there are inevitable consequences to lung function, including the destruction of lung tissue. And it's that destruction of lung tissue which leads to things like what we used to call emphysema and what we call chronic obstructive pulmonary disease. And while stopping smoking at any age will produce very significant benefit, it's also the case that in the case of the COPD patient, lung damage will stop, but lung repair of what has already been destroyed probably is not going to occur. And the second point I would make here relates to cancer. And that is that if an individual has smoked for 25 years and then stopped smoking, lung cancer and other tobacco-related cancers, esophagus, throat cancer, bladder cancer, are all develop as a consequence of exposure to the carcinogens in tobacco smoke as they are distributed throughout the body. And if the exposure to those carcinogens has been significant enough, cancer will result. And cancer may take many, many, many years to declare itself. And so one of the saddest ironies that I think all of us as clinicians have encountered are those individuals who stopped smoking 12 years ago, but who smoked 2 packs of cigarettes for 30 years and now are suddenly developing, not suddenly, are now manifesting or have developed lung cancer, and who say, well, I stopped smoking, how could this possibly be? So there are long-term consequences of smoking which never entirely disappear. From the cardiac standpoint, within 12 to 18 months, all of the changes that smoking produces, and they are very significant and are associated with virtually every puff of a cigarette in terms of cardiac function and vascular function, begin to recover. And so the risk of cardiac issues from a smoker who stops is within 18 to 24 months brought back pretty close to those of being a non-smoker, because so many cardiac incidents and events are acute events, and the precipitation of those acute events can be prompted by exposure to the products that are in tobacco smoke. So I hope that's not too complicated an answer for what's a very appropriate question. I guess the ultimate conclusion, though, is that it's never, ever too late to stop smoking.
Thanks, Dr. Pipe. That's a very encouraging sort of sum up of the longer term risks. There are many people online from our patient population, and that is very encouraging to hear, that it is indeed never too late to stop, and your heart will thank you, your lungs will, and the people around you will also thank you. So that's terrific. The second question I have relates to the very interesting emerging information about the risk of developing COVID-19 infection and how we relate that to smoking. And I think we're seeing that in a number of areas of health where there's some controversy, there's some mixed messaging, and I think you pointed out both sides of why smoking might be a bad thing in terms of perhaps making you more susceptible to harm from the infection, but also this kind of puzzling and intriguing information that smoking might actually be protective. Just want to be clear, are we recommending that people should start smoking to try to protect themselves?
Well, absolutely not. And one swallow does not a spring make. And that's why I tried to emphasize that the information that we're acquiring and that's been distributed only in the last 3 or 4 weeks is very, very preliminary. It's very early, and it requires much, much closer examination. But I thought it would be of interest to those participating today to understand what has been happening and the potential rationale. I would also say that several weeks ago, as you will recall, early in the conversation, I pointed out that the COVID-19 attaches itself to these ACE2 receptors. And many weeks ago, somebody or individuals said, oh, gee, we know that one of the things that increases the number of ACE2 receptors are, in fact, individuals taking ACE inhibitor medications, which are a mainstay of the management of cardiac disease. And so there was this flurry of excitement. Gee, we should be telling people not to take ACE inhibitors. When after a much more detailed analysis and examination, it became quite clear that this was not appropriate advice at all, and that kind of relationship had very limited applicability. And so it's very important to recognize that rumors fly and facts travel by foot. And so it's going to take, I would argue, much, much longer before we assess the suggestion that nicotine may, in some individuals, afford a degree of protection. And certainly the authors of those kinds of discoveries have taken pains to point out that they are not suggesting that people stop smoking, but that if in fact their theory is shown to be sound, that modifications of a nicotine molecule might form the basis of medications that can be used in this way, by way of example.
Great. Thank you for that clarification and follow-up. A couple of items relating to folks who might be interested in stopping smoking, which is a laudable thing to do in this time. Difficult, you pointed that out, that in these stressful moments, stopping smoking may be the furthest thing from your mind. If it is, that's terrific. You outlined the importance of the available virtual supports or online or telephone help. If someone was at home wanting to get linked into a virtual kind of program, how might they do that?
Well, great question, and I think the question also reveals an opportunity which we hopefully will respond to dealing with. I would, in the first instance, if you are at home and don't have access, for instance, to the kind of resources that may be available through many cardiac rehab programs, that the hotlines, the quit lines that are offered in many provinces. In some provinces, these are organized by the Canadian Cancer Society. In other settings, they're organized by public health authorities. That's a very, very good place to start. I think you can go online as well and find some intriguing programs online that might be of assistance. I would be very careful, though, that as with all online iterations of various approaches, some of them are more commercial than they are necessarily appropriate. We have, in terms of the Ottawa model, we have some YouTube videos that are available online. So I would, at the risk of being self-referential, suggest those are approaches. But I think there's much more that we can be doing and undoubtedly will be doing in the future to provide that kind of assistance.
Terrific. Well, thank you for that. And folks who are visiting our web platform at the Healthy University, you'll find links out to the Ottawa Heart websites as well, for where you'll find great information about smoking cessation, as well as all of the other great aspects of prevention and rehabilitation. I think we have time for just one last item, and again relates to the topic of cessation. I've learned from you over the years, Dr. Pipe, about maybe a more enlightened way of looking at how we can replace nicotine in its various forms. So we talked about patches today and gum and sprays. And the idea that we might need to use higher amounts than that might be, quote, recommended by the manufacturer, or that your docs may actually be aware of. But if people have been committed smokers for a long period of time, how might you suggest they have those conversations with their doctors to say, look, I'm struggling, and I really need more nicotine?
Yeah, a great question. And one of the good things that has happened, and you've alluded to it, Dr. O, is that many more clinicians are now are recognizing this reality. I think very often, if there are clinicians on the call today, if you have smokers who say things like this to you: Doc, I really want to stop smoking. I need your help, but don't talk to me about the nicotine patch, because the last time I used it, I just kept on smoking. They are telling you they were underdosed. Certainly, if we were prescribing antibiotics or medicines to control cholesterol, if certain doses don't produce the desired response, we increase the dose. If you're a patient having a conversation with a clinician, I don't think it's appropriate to say something like, Doctor, I am now aware that in many smoking centers, the experts in smoking cessation are advising that, if necessary, increased doses of nicotine replacement therapy for longer periods of time may be very helpful in achieving cessation. And I think that kind of approach can be very helpful, in informing clinicians who may not be aware of these realities, but also in ensuring that you get the assistance that may be necessary. I do want to underscore again, I don't want you to feel that everybody needs boxcar loads of nicotine replacement therapy or boxcar loads of other cessation therapies for infinite periods of time. But there's no question that many, particularly heavy smokers, will benefit from an increase in their dose of NRT and a prolongation of that therapy. And that typically then results in the question of, when do you stop? And I think that answer is also fairly straightforward. You stop as and when an individual is quite comfortable and confident that they can go about their day-to-day existence free of the symptoms of craving and withdrawal. And while they have been using nicotine replacement therapy and being smoke-free, they've learned a whole new array of non-smoking behaviors. And that's the way that we would gauge when it's ready for someone to discontinue nicotine replacement therapy. Although I should emphasize that before we discontinue, we generally taper down. And that again can be, smokers can with exquisite precision titrate their nicotine intake, and they know when they are getting adequate levels and avoiding discomfort. And so many of those decisions can be left to be addressed in association with the smoker themselves.
Great. Thank you very much, Dr. Pipe. We're reaching the top of the hour. This has been a tremendously informative session, jam-packed with very useful information. One of our colleagues online has provided an excellent sum up for this. Quote, "This was an extraordinary session. Thank you very much." Thank you to Dr. Pipe for sharing his time and wisdom with us. There's no question to the group of why you are Canada's foremost expert on smoking cessation, and why Ottawa Heart continues to lead the mission on prevention and rehabilitation across the country. So thank you for spending your time with us today. I'll remind folks on phone that tomorrow is one of our Nutrition Wednesdays, and we'll be talking about ketogenic and intermittent fasting diets. Our dietitians Fatima Ajwani and Veronica Rouse will be leading us through that session. We thank you very much for participating today. We wish you all a healthy Tuesday. Maybe you'll get out there a little bit, enjoy some air, but do stay safe and stay well. Thank you all.